All right, I think people are continuing to trickle in here, but in the interest of time, I'll go ahead and get started. So we had several topics left over from the end of Stu's PowerPoint the other day on total knee. We'll go through the remainder of those slides, some of the leftover topics, and then hit some rapid fire stuff more for the junior residents who haven't rotated on the service yet, to kind of reinforce some of the highest yield topics that come up on the test. I'll try and go as quickly as we can, since I know, coming up on test day, everyone's wanting to make the best use of their time at this point. So for the first part, I'll try and go fairly quickly, and then at the end, any seniors who are already familiar with some of the more elementary stuff are welcome to sign off, and we can kind of go through in a little bit more detail some of the fundamentals that are highly tested for the juniors. So for total knee, the remaining topic, total knee revision. Most common cause is going to be aseptic loosening. Infection is a clear second, and you can see some of the other reasons there. For the workup of a painful total knee, again, it's, like many other things, always has to start with a history and physical. Prior x-rays are important, especially if you have anything preoperatively to kind of show what was going on before the total knee was done. And you can see there that kind of the standard films that you would get in the workup of a painful total knee. CT scan really only comes into play if you're looking at bony defects or maltracking, for something involving the patella. And then a bone scan can be helpful if it's negative, where it rules out loosening, but if it's positive, it doesn't really clue you in on anything specific. So a bone scan, if it's used, is more to kind of reassure yourself that everything is okay. And it's okay to, kind of nurse the patient along with more conservative measures. The biggest thing for workup of a painful total knee for the OITE, though, is definitely infection workup. Even if you're given a stem that very clearly is leading you towards, flexion instability or aseptic loosening, and it seems like that's what's going on. If there is an answer choice that is order an ESR and CRP, that's going to be the right answer the majority of the time, because they always want you to do a workup. Revision principles, using the most lateral incision is important if there are multiple present. A TTO or a quad snip can be utilized. You can see kind of diagrams of the quad snip there, and then an intraoperative photograph of a TTO. If they're asking about quad snips, it's usually in the context of, the fact that you can do normal rehabilitation afterwards, and that it typically doesn't cause many issues. TTOs will sometimes come up in the context of patella baja. And then, similar to any other total knee, you're going to balance ligaments and then try and get the least constrained implant possible. When it comes to bony defects, for small defects, you can use a screw with cement. Now, here you see the screws before cement is put in place, but that's really only useful for relatively small, less than a centimeter defects. For larger defects, you can use a sleeve, which actually links into the component, or a cone, which is unlinked from the component. And I think it's more typical to see a cone used with the OC guys here. Again, implant selection is based on stability, use the least constraint possible, and you can escalate as necessary depending on what kind of issues you're having with the specific revision. When it comes to periprosthetic fracture, we'll go through all three here: distal femur, proximal tibia, and patella. Obviously, you can see there some of the kind of intuitive risk factors for development of a periprosthetic fracture around the knee. Here's a classification system, the Lewis and Rohrbeck classification. I have not seen this tested, but it is out there, kind of based on whether or not the component is intact and whether or not the fracture is displaced. which can be useful for distal femur fractures. And I should say, Dr. Masanis, if you have anything to add, feel free to weigh in at any point here. For femur fractures in the supracondylar area, typically you're not going to see non-operative treatment utilized, but if it's a non-displaced fracture, that can be an option with bracing as a possibility. Usually, you know, the question that we always run into on the trauma service is whether or not it's an open box design. And we'll get into a little bit of that later with different total knee designs. But the majority of the time on the test, they seem to lead you toward an ORIF with a plate in these situations. If an implant is loose, that's when you get into what is called a megaprosthesis or a distal femoral replacement, or a rotating prosthesis, and that's going to be, you know, a larger prosthesis which extends further up into the femur, and really should only be used for severe comminuted fractures with really poor bone quality. Generally on the test, if there's any way to fix it, that's the direction they're going to push you. Around the tibia, again, you can see the classification system there. Again, not very highly tested. A couple risk factors are a prior TTO, like what we saw in the revision slide a few slides ago, component loosening, malposition, or intra-op fracture due to long-stemmed implants kind of impinging at the tip of the stem. Typically, you're going to be fixing these if at all possible. Again, you can see they're non-displaced, possibly weight-bearing restrictions and a cast or a brace, but typically these are just going to be fixed. And if they're unstable, you're going to incorporate a long stem revision prosthesis. Patella fractures, the big buzzword that you'll see come up with regards to these is over-resection of the patella or compromise of the patellar blood supply. And if you have incisions on both the lateral and medial side of the patella, you can essentially wipe out all of the blood supply to it. So that is one that will come up on the test, as well as cutting it down to less than 12 millimeters. That places you at risk. There's some risk factors you can see there for developing a patellar fracture. And in terms of treatment, with an intact extensor mechanism, you will see some non-operative treatment, especially if the implant is stable. But typically, if you've got a patellar fracture with the implant in place, the implant's going to go with one end of it, and then you're looking at, you know, ORIF with or without a component revision, partial patellectomy with tendon repair, or patellar resection arthroplasty. Try to avoid a patellectomy if at all possible, both on the test and in real life. It causes a lot of issues, and there's a little, I don't know if this will play well, but just kind of showing the effect of a patellectomy in obviously just, you know, a rubber band and some sticks, but the mechanical advantage provided by the patella for knee extension makes a huge difference in functional outcome, and patients who have a patellectomy have very severe impairments because of it. So in real life and in the test, no matter how bad the patella is, you should try and do something to restore some of that because of how big a difference it makes in, you know, knee extension strength for patients. Patellar alignment will come up sometimes, and really all boils down to Q angle management. It's all about appropriate component rotation and avoiding increasing the Q angle. So anything that increases the Q angle, which is defined as the line between the pole of the quad, so essentially going straight down the quad, and a line right up the middle of the patellar tendon. Anything that increases that angle is going to increase the lateralizing force on the patella and increase the likelihood of it pulling out, of dislocating laterally or subluxing laterally. So when you think about this, you just have to think about anything that's going to result in that increased lateral pull. So if the medial tissues break down, that's going to lead to increased lateral pull because there's going to be more tension on the lateral side. If there's excess tightness on the lateral side, again, same thing, it's going to be pulling further that direction. If you're medializing either the femoral or the tibial component, very similarly, you're increasing that Q angle, and that's going to result in a lateral pull. And then internally rotating or valgus alignment of the components will also have a similar effect. So a lot of times you'll get on the OITE a question with regards to this, where it's going to ask you to just choose between like internal or external rotation of the femoral component, which one would lead to patellar issues, or medializing or lateralizing the patellar, the tibial component, which one's going to lead to issues. And you just have to think about it in terms of what's it going to do to the Q angle, and then it will typically make it a little bit, make more sense. And then we'll go through a couple of complications as well. So perineal nerve palsy, the most common deformity which will lead to this is a valgus inflection deformity. And if you look at the x-ray over here of this patient, you can see if you straighten that knee out kind of along this line here, it's going to result in a ton of tension across that perineal nerve, which is currently, bent a lot, essentially in a fixed position, and in a shortened position because of that deformity. And so as you straighten it out, that nerve is going to be experiencing tension. The classic question is, what do you do immediately post-op if someone wakes up with a foot drop? And it's flex the knee and remove the dressings. And you're not going to take them back to the OR. Typically, these are observed, with most resolving within a few months. 3 months is kind of the time point at which you start thinking about going back in to do a neurolysis. For an intraoperative MCL injury, again, for juniors who haven't rotated on the surface yet, the MCL stability has a lot. It plays a very important role in overall stability of a total knee. And so, what we're familiar with from like a sports rotation is where an MCL injury isn't that big a deal. In arthroplasty, the MCL plays a bigger role and can screw up your flexion gap. So if you do have this, the options are either a primary repair with a post-op brace, or converting to a more constrained prosthesis. So something like a varus valgus constrained prosthesis. And again, we'll touch on component designs in a little bit as well. But that is a very common question in terms of an intraoperative complication that you can see. Extensor disruption is almost always at the patellar tendon attachment to the tibial tubercle, and these can be real disasters. Direct repair and non-surgical treatment never work. I think Marlex mesh has been around long enough that it's probably testable at this point. And that's what you see here, this kind of long white strip that's coming out of the tibial base plate there. So Marlex mesh is a mesh that's used for hernia repairs. And essentially what you do is roll it up kind of like an anchovy almost, and sew it together, and then incorporate that into the quad so that it kind of functions like a patellar tendon. And outcomes with that are, reasonable. They're not as good as a native patella, obviously, and usually folks are left with a little bit of an extension leg, but you can get back some extension with that. And I think there's enough evidence for it at this point that if you saw a absolute disaster extensor mechanism failure, that could potentially be a correct answer. A post-op flexion contracture is going to be treated with therapy and is typically due to hamstring tightness and spasm. If they try and lead you down the road of going back to the OR for that, that would be the wrong answer. You're going to want to push them towards physical therapy and work on straightening it out. Femoral notching, you can see here on that total knee, essentially comes during preparation for the femoral component. If you cut too aggressively, and that is a risk factor for periprosthetic fracture postoperatively. Typically, if they ask you about this, they're going to show you an x-ray and count on you to pick that up. So you have to look kind of along the anterior cortex here. And if you're looking along there, you can see that it kind of takes a dive there because essentially the saw was coming in along this trajectory and came in too deep. So that's what femoral notching is. And if you see that, you will be at risk of a fracture down the road. Arthrofibrosis is another word for, a decreased range of motion, stiffness, flexion contracture. And when you see this on the test, the correct answer is going to be to only manipulate it early. You will see some of our attendings here manipulate these fairly late and insist that they're getting much better results with late manipulations than we'll typically see in the answers to questions on the test. But for OITE purposes, only take somebody back for a manipulation if it's within like the first 2 to 3 months. That's going to be the textbook answer there. And the reason would be, for the purposes of the test, that if you do it later, you're not going to see a positive. They're not going to regain much in the way of motion. For metal allergies, this is rare. And there's some controversy about how often this actually comes into play. But the most common allergy that occurs and that comes into play is nickel. And you can use components that don't incorporate nickel into them, which typically is going to be titanium. There's also one, I'm trying to remember, I think it's like zirconium that one company makes, which is another option.
That's right, oxidized zirconium.
And then real quickly, the surgical and perioperative guidelines from AOS. These are very heavily tested. So this paper right here, I think, is probably the most heavily tested paper on the OITE because it's very straightforward, and it's something that we all will have to do a lot. So I think it's worth just knowing what exactly it says on here. So for somebody with arthritis, they want self-management programs, strengthening, low-impact exercises, and physical activity. So essentially, that could take the form of exercise, physical therapy, something along those lines. Weight loss, the recommendation is only moderate, and it's for anybody with a body mass index of greater than 25. So I saw a question today that asked what recommendation was strong, and it made me choose between weight loss and exercise. And the correct answer was exercise, because that's going to be the first line thing. A valgus unloader brace is inconclusive. Glucosamine and chondroitin are actually recommended against. One of the things that you'll see, I think Stu mentioned this as well, mentioned is that tramadol is a strong recommendation. I don't think there's any way they're going to test that, because with everything going on with the opioid epidemic, that probably would not be the case if this guideline was updated. So they would probably ask you about NSAIDs, but again, that's a strong one. Acetaminophen is inconclusive. So, they could trick you by trying to throw NSAIDs and Tylenol out there, and the correct answer would be NSAIDs. Intraarticular corticosteroids are inconclusive, so that's not going to be the right answer. And hyaluronic acid, again, is recommended essentially against here, even though it's pretty widely used. Same story for PRP and growth factor. So I think this here is useful to know, because there will probably be one or two questions that come straight out of this clinical practice guideline. And they may even ask you to know whether it's a moderate or strong recommendation on the test. In terms of perioperative management, we can kind of blow through these fairly quickly here. Intraoperative navigation and patient-specific instrumentation would not be correct answers on the test. And I think this underscores an important principle for people who are taking the test for the first time. If they throw out something fancy and new and expensive, the answer is probably going to be to not use it. So 3D printed or, you know, intraoperative robots or that sort of thing. If somebody's asking that question, they're probably asking it so that they can say there's no evidence demonstrating superiority. And if you're not sure, you are always better to guess with the less expensive option when you're choosing between things and you're not sure whether or not you've got the right answer. Local anesthetic, peripheral nerve blockade are both strongly recommended. Adductor nerve block is going to be the one that you'll probably see on the test because it's sensory only. That's blocking the infrapatellar branch of the saphenous nerve, which is coming down around the medial side of the knee. Femoral nerve block is another option, but you knock out the quads with that, so they're not as commonly used. And tourniquets, if they ask about them, I think this is probably the only thing that they would say is that they increase short-term post-operative pain. But again, that's an area of a little bit of controversy, so I doubt that'll be heavily tested. And tranexamic acid would be recommended. If you get a question about tranexamic acid, regardless of the surgery, as Brad covered during his grand rounds recently, just pick tranexamic acid as a good thing, whatever option leads you in that direction, because it's pretty much good for everything, and it's been studied in just about every surgery now. And if anybody's asking you about it, it will be because they want you to say it's good. Drains, not supported. Again, I think this is probably not going to be a heavily tested thing. One thing that is fairly heavily tested is post-op PT and the timing of it. They want you to say starting on the day of surgery. So that they'll say post-operative day 0, or you know, immediate, or within 24 hours. That is a strong recommendation from this guideline, and that has been tested several times. CPM machines, just remember you've never seen one in our hospital, and there's a reason, so don't pick that. Okay, having moved through that kind of quickly, I wanted to move on to more of a junior focused portion of the talk, kind of focusing on things that you probably don't know if you haven't rotated, but that are likely to help you get a couple questions on the test right. And for seniors who have already rotated on the service, this may not be useful for you, so no hurt feelings if you want to sign off and leave this one for the juniors. But some of these have been previously covered in the total knee talk or the total hip talk. I just thought it would be useful to reinforce the highest yield points if all of this is a little bit foreign to you. So we will move on to that portion here.
Eric.
Yeah.
Eric, hey, John Masanis. Just before you go on, I think that was a good wrap up on the knee side, and just the highlights of things that I think you pointed out, which you could definitely expect, would be definitely expect to see infected total knee. And you're right, they might try to lead you down a different path, but checking your infection markers or your aspirate is going to be your answer. any rotational malalignment to the knee or any subluxation of a patella you're right, the answer is going to be malrotation, and your answer is check your CAT scan. So that was definitely something you pointed out, which I think is important. And I think you'll definitely see a periprosthetic supracondylar fracture, and they should make it pretty obvious if the component's loose. So they should either tell you the patient had prodromal symptoms of pain with walking or whatever it may be, but they'll show you somehow if the implant was loose and you have a comminuted fracture if they're going to ask you to revise the implant. Otherwise, like you said, most of the time it's going to be a periarticular plate. And I think you'll get into this at the end, but when they talk about, just for the juniors, just explaining that, a hinged total knee requires no collateral ligaments. So just to help them out on that. But I think you're getting into that soon. So, all right, that's it. Go ahead.
Hey, Eric, it's Brian Springer. The only other thing I'd add, because I was thinking the same things John was, is they'll give you probably an early post-op patellar tendon rupture, right? For, a patient that's 2-3 weeks out, fell, ruptured patellar tendon. They'll try and lead you down the path of a primary repair, right? Which you nicely outlined don't work, but they'll try and trick you with its early post-op. Oh, I can just go in and repair it.
Yeah.
So that's the other thing. Just remember, primary repairs in those situations don't work.
Yep. Okay. So I'll jump back on here. Kind of going through some of the highest yield topics here. Here's the orthobullets page, and the biggest thing that should jump out to you here is that prosthetic joint infection is far and away the most heavily tested item. So we'll hit some of the high points there. Obviously not going to be an exhaustive review of this, just trying to set you up to be able to pull some points out of that. So MSIS criteria is definitely worth memorizing for the test. One major, so if they have a sinus tract, if you are in clinic looking at their prosthesis, they are infected, or 2 positive cultures is an automatic, into the infection category. And then for the minor criteria, they've got to have 3 out of 5. So ESR, CRP, white blood cell, polys, a frozen section where they will ask you like how many cells a pathologist saw per high-powered field, or 1 positive culture. And they will get granular enough on this that they will give you 2 out of 5 of the minor criteria. And the correct answer will be to take the patient to the operating room to obtain an intraoperative biopsy so that you can make a definitive call on how many cells per high-powered field there are. If there is one thing to take away from this, is that you should memorize this slide, because this slide will probably be 3 or so questions on the test. In terms of management of a periprosthetic joint infection, they're probably not going to ever ask you to do a component retention debridement type procedure. They might. If they do, it's going to be very, very clear. Like the patient was doing fantastic, had no pain whatsoever, and became acutely septic with a terrible abdominal infection and developed symptoms, 24 hours later, and it's been 72 hours since then. It's going to be like that type of very, very clear-cut indication in order for you to go back in and do a debridement. The terms they may use for that would be like a debridement with polyethylene exchange, debridement with implant retention or component retention, something along those lines. Otherwise, you're going to be doing a 2-stage revision arthroplasty where you're taking it out, leaving an antibiotic spacer in for a long period of time, treating with antibiotics, and then eventually coming back to put in a new one. And one other thing that will come into play in the workup for these is alpha defensin. I think there were 2 questions about this either last year or the year before last. Alpha-defensin is a molecule produced by the immune system that actually is involved in attacking bacteria. It's not specific for any one bacteria, and it is very useful in ruling in or ruling out infection, but importantly, it is not a part of the MSIS criteria. So it's kind of one of those things that eventually probably will be incorporated into some future updated criteria, but it is not currently. However, it's a very useful test. One thing that is useful to know is that even when it is incorrect, the addition of a synovial CRP can increase its utility, increase its accuracy, and that is typically a part of the lab results that we get back when we send off that test from OC. So if you get a question about alpha-defensin, be thinking synovial CRP as a useful adjunct to that. Jumping back to spacers, just so juniors know what a spacer looks like. I think when you think about a masque for trauma, you're typically thinking about a ball of cement that's kind of sitting there statically. And sometimes that's utilized for a joint spacer, but a lot of times it's a dynamic spacer. And this is an X-ray here of a dynamic spacer for, or an articulating spacer would be another term for it, for a total knee that was infected. And it probably looks a lot like a standard total knee. What you're looking at is, if you kind of look at this up here, that's just a K-wire with or a dowel with cement on it that's been run down into the canals. And so if you were looking at this X-ray, that would be the giveaway that you're looking at an articulating spacer there. Articulating spacers have some significant benefits. Obviously, patients like being able to move their legs. It's got some range of motion benefits post-operatively as well. So that is something that could potentially come up. Moving on to, yeah.
Eric, just on that topic, 2 prior questions that I've seen would be the static spacers tend to have more bone loss at the time of second revision, and the articulating spacer allows for easier exposure next time in, just because the knee's been somewhat flexible. Yeah. So those 2 things might show up.
Yeah. So I guess if you're asked to choose between an articulating and a non-articulating spacer on the test, I would probably just choose an articulating spacer.
Yeah, I think the only caveat to that would be massive bone loss or a disrupted extensor mechanism.
Yep. For periprosthetic fractures, this is another very heavily tested one. If you have fractures around the trochanter, so a lesser or a greater trochanter fracture, those can be treated non-operatively. And I think there's some controversy there about whether or not 2 centimeters of displacement is a legitimate dividing line between operative and non-operative management. But if you get a trochanteric fracture, you're going to be looking at patient function. Are they able to get around? Are they able to walk without a cane? And if they are, they're probably leading you more towards non-operative management. A B1 fracture is around the stem or just below it with a well-fixed stem. So you're just going to fix the fracture around the stem. You're going to leave it in place. B2 is the most common thing that you're going to see on the test, which is the same thing, but the stem is loose. Stem is loose and you have good bone stock, so you're able to get a new stem in, but the current stem is not going to be stable enough once the fracture is fixed. And here the correct answer will be revision to a long porous-coated cementless stem with fixation of the fracture. And you'll also see like a modular tapered fluted stem is another buzzword that they like to toss out for those, for the kind that you're going to use. And essentially what you're trying to do is you're trying to get into the diaphysis and get control of the fracture and the diaphysis, and then fixing the fracture around that so that your stem stability is coming from distally rather than proximally. For B3s, this is where you start getting into proximal femoral replacement. And if they're going to do that, they're going to make it obvious that there's like absolutely no bone left whatsoever in the proximal femur. The vast majority of the time when they ask about this, it's going to be a B2 fracture, which aligns with real life because the majority of these types of fractures are B2 fractures in real life as well. Anything you'd add there, Dr. Masanis?
Yeah, you'll definitely see a B2 fracture or a B1 fracture, probably both actually on the test. So I think they'll try to give you some hint about a loose stem. So one hint, they might tell you had prodromal pain prior to the actual fracture, which would suggest the stem was loose. And then they might show you a B fracture, and they'll show you an earlier image and then a late image. And you just want to look at the position of the implant related to some bony landmark. So either the greater trochanter or the calcar or the lesser, and take a look at the two images and see if the stem has shifted or moved, which could confirm for you that you have a B2.
Eric, the only other thing to add there is that if you get an A fracture and a lesser trochanteric fracture in the absence of pain, it's going to be, they'll test this pretty frequently. That's a metastatic tumor, metastatic lesion.
Yeah. Moving on to wear and osteolysis. This is another heavily tested thing. I think the testing frequency on this has gone down over the years. But the important thing to understand, especially if you haven't put any of these things in before, is that a lot of the problems historically with arthroplasty components revolved around the wear rate of the polyethylene. So that would be on the far left here, the cobalt chromium polyethylene, where they show the huge pile of stuff coming off of it. That got a lot better after they began using cross-linked polyethylene. And this, I think this is an ad from like Stryker or something, where they're showing their new cross-linked polyethylene that, you know, has a smaller pile of stuff coming off of it. But if they ask you what bearing surface results in the lowest amount of you know, debris, it's going to be ceramic on ceramic. And the reason we don't put ceramic on ceramic in everybody is there's problems with squeaking. There's also problems with the with fracturing of it, and because of those, and because the cross-linked polyethylenes over time have shown such good results, the indications for ceramic on ceramic are decreasing as the highly cross-linked polyethylene is showing more and more, you know, long-term lack of osteolysis around components. You also see metal on metal there, which we'll talk about in a second. If they talk about osteolysis, a couple important things to remember is just the inflammatory cascade. It's going to be all the usual suspects. TNF alpha, IL-1, IL-6 are going to come up. Macrophages are the cells that are actually causing the damage. Cathepsin K is another one that's going to be a component of it. And it's pretty much all of the things that you would think. It's all of the things that are involved with bone breakdown typically. They may try and get you with lymphocytes. Lymphocytes are for metal on metal, not for polyethylene wear. And then you will see osteolysis around what is known as the effective joint space, and that's on the right here, anything outlined in red. So anywhere the implant is touching is considered a component of the joint space, unless you have ingrowth circumferentially around your stem, in which case you've limited some of that joint space. But you can see osteolysis all around all of that, and all of that is considered a part of the joint. So if you're used to thinking about a native joint where it's just the, you know, synovium and what's contained within it that you consider part of the joint, for an arthroplasty component, the effective joint space becomes a lot larger. They will potentially ask about metal on metal hips some. Here's just for, if you haven't seen an x-ray of these before, it can be challenging to identify when you're looking at one. This is actually a patient from Dr. Mason's clinic who had a metal on metal hip on one side and a polyethylene on the other. And this right here, I don't know if you can see me circling here, these areas are where you can look to see some of that polyethylene essentially being more transparent. And if you look over here on the metal on metal side, you don't see that same transparent area. And so if they give you a question where they have an x-ray and they show a hip like this where you can't see through any of it, they may be leading you down the metal on metal workup pathway, which would not be the case if you could see through a part of it right there, indicating that there's some polyethylene in that coupling. For metal on metal hips, it's very controversial, and it's a challenging thing to test. But a few areas that they could test would be edge loading as a risk factor for the development of metal on metal debris wear. So if you have a high abduction angle, a low functional arc, or a small size, all of those are going to contribute to edge loading. And then you lose a fluid film lubrication when you have edge loading of a metal on metal hip. And that is theorized to be one of the things that can lead to metal wear. So if you see anything about edge loading as a risk factor, that could be an option. They may ask about ion levels. 7 parts per billion is kind of the magic number for whether or not it's concerning. That doesn't necessarily correlate with MRI findings, but that's a number that you may be asked to remember. It's important to know that it's lower if you're working up somebody for trunniinosis, which is also related to metal debris, but obviously in lower volumes. And then if you're working somebody up for this, a really common question will be, it'll be somebody with a metal on metal hip and you're doing an infection workup, and the answer will be that you need to do a manual cell count because the metal debris can actually screw up an automated cell count if you're doing a joint aspirate and trying to get a white blood cell count. So somebody has to actually look under the microscope at it. And then if you're going to do an MRI, it has to be a metal subtraction sequence, which is called a Mars MRI. And what you're looking for on that is what's called a pseudotumor with small thin-walled lesions possibly resolving and possibly being appropriate for observation, but larger thick-walled lesions being more problematic. And I realize I'm opening a can of worms by talking about metal on metal hips here, but is there anything else you guys think might be testable for that topic?
I think the trunniinosis is probably more germane here. And the other thing, which I don't know if you're getting into, would be questions about resurfacing.
Yeah, I've got some on resurfacing at the end here.
Yeah, so I think just knowing if you have a relatively benign looking hip replacement, maybe a small amount of osteolysis, but it's increasing pain. I think, looking at metal ions and considering trunniinosis as a potential issue, they'll usually give you a scenario of a revision or something along those lines. But I think that's probably, like you said, the metal on metal testing falling out of favor a little bit on the in-training, but the trunniinosis is certainly still up and running.
Yeah. The only other thing, Eric, I could think that they might ask is sometimes the confusion about an infection in a metal hip replacement because of the debris, right? Giving you a falsely elevated cell count and differential. So, and I think I've seen on there in the past that if you have a metal hip replacement that you want to ask for a manual differential because you can get a falsely elevated cell count and differential in a metal hip if you just do an automated cell count. It's possible that could be on there.
Yep. Yeah, that's come up before.
Okay.
Moving on from there, for total knee designs, this will come up in a variety of contexts, and I think it's useful to know just exactly what people are talking about when these come up. And I think the easiest way to differentiate them is based on how they're driving femoral rollback. So there's a medial pivot with knee flexion, and all of these different designs have a different way of either replicating or preserving that motion. So going from least constrained to most constrained, a cruciate retaining, as you can see on the there, people are mostly familiar with this from other services. When we talk about somebody who has a periprosthetic fracture, and we're trying to figure out if it's a cruciate retaining implant, because then we know it has an open box and we can put a nail through it. So that's, you can actually see part of that there with the open box, and it's the PCL itself that's going to be driving the rollback there. On an ultra congruent, other terms for this would be like a deep dish type of implant. What you're looking at there is this kind of almost like a shelf there, and the another term for that would be highly congruent. So that highly congruent medial side is going to drive your rollback there, because the medial side is not going to move as much. Whereas you can see obviously on the lateral side here, it doesn't have that big shelf that's kind of holding things in place. When you get into posterior stabilized, that's where you have this cam here, and inside, or excuse me, that's a post. Inside of the femoral component, you have a cam that will actually engage on that. And so there's a bar that will hit that piece of plastic that is coming up in the notch and actually push the femur back as you go into flexion. A very similar thing for the varus valgus constrained implant, but look at the amount of space around the post here as compared to here. And you can see that there's a lot, you can see through a lot more of the plain posterior stabilized one, because as that post gets bigger, it's going to take up more space in that notch and restrict motion more. And so that's a varus valgus constrained. And then you get into a rotating hinge where they're actually linked. So there's literally a hinge between the femoral and the tibial component. And in that case, you're not getting the same pivot because it's just rocking back and forth on that hinge. And there's kind of the motion that you'll see in the native knee, where the medial side is not rolling back as far as the lateral side. And all of these are just various attempts to preserve that, or in the case of the rotating hinge, you're going to sacrifice it because you need the increased stability. But obviously this is robbing Peter to pay Paul, and as you do this, you're transferring more forces to the prosthesis and setting yourself up for potential implant loosening. So you want to use the least constraint possible while getting yourself a stable prosthesis, and these are kind of the options that that you'll use. For hip dislocation, I think the most common way they're going to talk about this is in relation to the hip-spine relationship. And I think it's important to just know that if you see somebody with spine pathology on the test and they're talking about it in the context of total hips, they're probably asking you about dislocation. And the other thing I think is important to know is that they don't necessarily have to have, you know, an instrumented spine. So they don't have to have interbodies. They don't have to have rods in their back. You can have a stiff spine just with degeneration if you're not accommodating through motion. And so you can have somebody dislocating because of their spine just because it's degenerative, because it's gotten to the point where it's not moving anymore. And if they ask you about this, you know, what are you going to do intraoperatively? They're going to be talking about anaversion, and I think anaversion is I struggle a lot with visualizing anteversion. This is on the left here is kind of how you can measure that, and on the right there is kind of showing what it looks like with varying degrees of anteversion. So if they give you a question where they're trying to convince you to do something different intraoperatively, that's what you're going to be doing, and that's what anteversion looks like. A little bit of a complicated topic to try and dig through here, but that's the short version of it.
Eric?
Yeah.
What's going to get asked there is there's now several different studies that have looked at correlating the number of levels of fusion with the risk of dislocation and revision. So if you see a multi-level fused spine, the question is going to focus not on what do you do for sagittal balance with your components. It's going to focus more directly on, because that's still evolving, it's going to focus more on is this patient at higher risk for infection or dislocation or revision, and it's for dislocation and revision.
Okay. Dual mobility, I don't think is likely to be tested, but just so you guys have seen it, this is what a dual mobility implant looks like, and dual mobility is used to try and decrease dislocation risk. Again, I don't think this is something that's likely to be tested, but if it comes up, this is what it is, and essentially you're getting literally dual mobility. There's two articulations that are mobile in that type of implant because you're trying to increase functional range of motion and decrease the likelihood of dislocation. And they are effective at decreasing dislocation. I just don't know if that's something that's really testable yet.
They're going to test on, they have tested on that in the past, and they will test also on your ability to recognize a inner prosthetic dislocation.
Yep.
So be aware if you see a dual mobility and then you see it dislocate, it looks a little bit funny, shifted just a little bit, look for that as a potential answer.
Yep. And the classic prompt for that would be somebody who had dislocated their hip, and in the process of getting it reduced, they got that intraprosthetic dislocation. I think is that fair, Dr. Mason?
Yeah, it could be structured a number of different ways from a question perspective, but if it looks a little bit wonky, that's likely what it is. They'll show you an X-ray.
For templating, for the purposes of the test, just take the circle that is in the end of the stem, so this one right here, and move it so that it is corresponding to the other circle, and that is what you're doing. So in this case, if I take this circle in the center of the end of the stem and I move it this direction, I'm pushing out this direction, which is increasing offset. Here, if I move this down, I'm going to be increasing leg length. And usually when they ask you a templating question, it's just to see if you can line up those circles and correctly deduce what's going to happen when you put the center of the femoral head in the center of the acetabulum. What offset is for juniors who haven't rotated before, there's kind of the diagram of it. And one of the reasons that we care about offset is because if you have decreased offset, it can lead to impingement, which can then cause dislocation. Obviously, we'll talk about the free body diagram around the hip in a moment here, but that is another reason why offset becomes a concern, is because of the impingement risk, in addition to wanting to have appropriate tension on your abductors. So for hip biomechanics, I think this is something that's hard to conceptualize, and I think some of the ways that it's explained make it harder. So what you see there is the most common diagram of the free body diagram around the hip. And so what you have is the abductors pulling up in that diagram and body weight going down, which is I think how most people usually think of it. But and I'm going to stop sharing here. Let me see if this works. But if you just think about the hip as a fulcrum, I have taken one of my daughter's toys here. In that diagram, you are pushing down with body weight like this, and then pulling up with the abductors because the abductors are pointing up. It doesn't make any sense because you're not actually balancing it. So what the abductors are doing is they're actually pushing down. And the reason they're pushing down is that your foot is fixed to the floor. So you can't abduct if your foot's not moving. And so when you see one of those free body diagrams and they're showing the abductors doing hip abduction, that's not actually what's going on, because if your foot is stationary, your hip can't abduct. And so they're not pulling up and abducting. They're actually pulling from the femur on the pelvis and pulling the pelvis down and exerting a downward force to balance the downward force of body weight. And if we go back to this, so don't think about it. Are you guys seeing my screen again?
No, not yet.
Okay. Let's see. Is that is that working now?
No.
All right, how about now?
Negative.
I screwed it up trying to show my kid's toy.
Worth it.
Let me see. Is that working?
Yes.
Okay. So don't think about this in terms of, actual abduction. I think a better way to conceptualize it is with clockwise and counterclockwise torque. So body weight has to be pushing down and the abductors have to be pushing down too. And what that results in is balancing of clockwise torque versus counterclockwise torque around the center of the hip as the fulcrum. And then you have to obviously incorporate, the distance from the center of the hip to the center of mass and the difference from the center of the hip to the trochanter in that equation. But at least for me, it helps to think about essentially as flipping the origin and insertion of the muscle, where the origin is actually the femur and the insertion is actually the pelvis, and it's pulling it down. And the Trendelenburg gait questions kind of illustrate this, because what's happening is the muscle is weak and it is failing to pull the pelvis down to the femur when the foot is fixed to the floor. So for free body diagrams around the hip, I think that kind of torque component of things helps it to make a little bit more sense to me when I run into those questions. I don't know if I'm confusing people more with all of that or not, but at least conceptually, I think that helps make it make sense, and it's typically a fairly confusing concept. For gap balancing a total knee, what you just have to remember is what's in contact with the tibia in the different knee positions. So if you're in extension, your distal femur is in contact with the tibia. And so in an extension gap, you're going to work on the distal femur. You're going to either add to it or take away from it. And in flexion, the posterior femur is in contact with the tibia. So if you have problems with your flexion gap, you need to do something to the posterior femur. And that is kind of just a simplified approach to it. Obviously, you're going to have to remember, how you're going to add on to or take off for the various circumstances. But if you just remember distal equals extension and posterior equals flexion, you'll usually be almost all the way there to getting those questions right. And then obviously if you have both and they match up, you're going to go to the tibia because the tibia affects both. And then I think this is the final topic. So hip resurfacing, just for those of you who've never seen one, I think it's useful to know that it is a thing that you can see, and there are only a couple questions you'll be asked about it. One of them is it does have a metal-on-metal articulation in it, so you can see some of the issues related to that. Another one is they're very high risk in women and are typically mostly used in men, and that failure rate is independent of like body mass or component sizing. So if you're ever getting a question about a hip resurfacing and it's a woman, you know that you don't want to put a hip resurfacing in a woman. And then it also has a not fully hemispherical shell. If you look at the hip resurfacing there compared to the total hip, you can see that it's not a full hemisphere. It's just a portion of one. The only other thing that I think is likely to be tested about them is the major complication is a femoral neck fracture, kind of around the base of it. So that's kind of all the topics I had, and then I thought I would close with, for those of you who haven't done joints yet, why you will love joints, which I thought was a cool study out of here, where they showed that arthroplasty fixes depression more effectively than antidepressants. And so for those of you who haven't been on joints yet, when you come onto the service soon, you will have the joy of working with very happy patients. And if anybody from the attending side has anything else to add, we can do that. Otherwise, I think that'll be it for tonight.
Eric, thanks. I think that's a great review. Hit some kind of high yield topics. So at this point in the study realm, that's probably worth doing. And happy to answer any questions. Anybody has individual questions or wants to go over a topic, you can just email me, ping me, or one of the other attendings, certainly before the exam, and let us know.
All righty. Thanks everybody for signing on, and we'll let you go.
Thank you, Eric.
Thanks, Eric.